Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about foot problems, including heel issues like plantar fasciitis, bunions, foot fungus, and toe fungus, and the serious relationship between diabetes and the feet. Tonight's guest is podiatrist Dayna Bolton. In the second half hour of our program, we'll be taking your questions, like we always do, live by phone at 504-866-3200. That's 866-3200. And by email. You can email your questions to us right now at hhquestions@wlae.com. Well, Dr. Dayna Bolton is a native New Orleanian. She got her undergrad training at Dillard University with a major in biology. Before that, she was at McDonough 35. She received her doctoral degree from the Ohio College of Podiatric Medicine. That's in Independence, Ohio. She completed a rigorous residency program with an emphasis on wound care and foot surgery at the Boston Medical Center. Dr. Bolton is board certified by the American Board of Podiatric Medicine and the American Board of Wound Management. And Dr. Bolton treats a wide variety of foot problems, including diabetic foot management, wound care, sports injuries, and foot surgery. She joined the Ochsner family in 2011, and it is our pleasure to welcome Dr. Dayna Bolton to Hello Health. Good to have you with us on the program.
Hi, it's great to be here.
Thanks for being here. And speaking of family, yours is an expanding one, right? Congratulations.
Yes, thank you. I have a little baby girl.
Good for you.
Yes.
Yeah.
5 months.
5 months. Excellent, excellent. So remind us or tell us, what was it that first interested you in medicine, and how do you think you ended up in podiatry?
I've always wanted to be a doctor my entire life. I just wasn't always exactly sure the type of specialty that I wanted to go into until I was at college, and podiatry kind of fell into my lap. I was introduced to it and fell in love with it. And from there, it was a fast-forward case straight to where I am now. So.
And you said you thought about OBGYN and
did.
Then thought again?
I thought about it and I said, I don't know if I really want to do that. Just the long hours, and I said, I want to do something a little bit different.
You said also that you had foot problems yourself.
I did. So I had a plantar wart, and I treated it myself when I was in high school, senior year, and I said, hey, this is pretty interesting.
I can do this.
I can do this.
All right. Let's talk about some of the most common foot problems that you see.
Well, I see a lot of different types of problems, but the main problems patients present with are going to be heel pain, patients who are presenting with bunions, patients who have fungus, whether that's nail fungus or fungus on the skin, and then patients coming for a diabetic foot management or wound management. But out of all those issues, by far heel pain is going to be the most common presentation to my clinic.
Okay. Plantar fasciitis is the official term for most heel pain. So talk to me about what is plantar fasciitis.
So plantar fasciitis, simply put, is an inflammatory condition of the heel. So as you can see on the picture where the little orange spot is. That's where most of the pain is with plantar fasciitis. It's an acute inflammatory condition to the heel. Sometimes it's confused with the heel spur. To me, I tell my patients they're synonymous. They're basically the same thing. We treat them the same way. Key features of plantar fasciitis is going to be patients who have pain when first waking up in the morning. That's called post-static dyskinesia. So as soon as I have a patient in my clinical chair and they're telling me, Doc, as soon as I wake up, I have to grab the wall. I'm in so much pain. I automatically know 9 times out of 10, we're dealing with plantar fasciitis. That pain is worse in the morning and tends to improve throughout the day. Generally, as you walk, so if you were to wake up in the morning, when you first get out of bed, there's pain. Go brush your teeth.
Middle of the night, right? Yeah.
Middle of the night, if you have to get up to use the restroom, extreme pain. As you tend to walk it out, that pain improves. As you can see on the image, that white band is the plantar fascia, which I tell patients to think of it as a ligament. Basically, it's for support and structure, and you develop the inflammation right at the origination of that point, right on the heel.
All right. So I've been doing this show for almost 7 years now, and usually going into the program, you know, I don't have that. I will probably never develop that. Although sometimes at the end of each program, after listening to the symptoms, you know, backache, tough sleeping at night, you know, whatever, I go, wait a minute, I may have some of these things. This is the first show that I'm aware of that I've come into knowing or strongly believing that I've got something we're going to be talking about tonight. So I want to let our viewers know we have never had a nude scene on this program, but we will tonight. Now, before you get too excited or before you run to your television and turn it off quickly, we're talking, I just want to let you know we're talking about just the feet. But we are going to do that tonight because the doctor has been kind enough, and I really appreciate you for doing this. For working on off hours.
Yes.
But 2, for taking a look at my foot here. And do I even need to take off my sock or no?
You don't have to take off your sock.
So it won't be a complete nude scene, which is probably better anyway. But so the doctor's going to take a look at my foot here, and we're going to diagnose and see if that's what I've got. So go right ahead, as you would do this normally.
After my patient will kind of give me a description of what's going on with the foot, and I'm usually going to already have a working diagnosis in my mind. I say, well, let me see your foot.
So everything you've just described, by the way, is right. So you get up in the middle of the night or get up in the morning, and it is deadly painful and does go away and get much better throughout the day. So,
and that medical term is called post-static dyskinesia, which just means pain after periods of rest or pain when you first wake up in the morning. Clinically, when I'm trying to do an evaluation, let's see this foot.
Okay.
Main place I'm going to touch is say, hey, do you have pain right here in this part of the heel?
As if you're doing it there, no, I really don't.
Because you're not walking right now.
Okay.
If you had been having a long period of rest, generally the pain is going to be here. With plantar fasciitis, most patients' pain is going to be right here on the heel, or they have pain in the arch. Usually,
and that where you just touch is where it would normally be. That's right.
That's right where the plantar fascia is the tightest. So when you step down, that fascia stretches and tightens, and it's very tense right here in this area. So most patients, maybe 70% of patients have pain here. Other patients, the pain is right in the arch.
Okay. Now, so let's say you've diagnosed it. By the way, who is at the greatest risk for developing plantar fasciitis?
Greatest risk, number one, is going to be obesity. So patient's weight. If you're very heavy, you can develop plantar fasciitis just from the weight that's on the foot. Another thing is level of activity. So, and a lot of times this frustrates a lot of my patients who are obese because you start a new exercise program and you're doing things you've never done before, and all of a sudden, oh my gosh, my foot is killing me. That's starting a new level of activity that your body's not really used to. That can cause it. Often, shoe gear choices will cause problems with plantar fasciitis. I get a lot of patients with this in the summertime, especially women, because we wear a lot of sandals and flip-flops. Shoes are not supportive, and they kind of smack the back of the heel. That can cause this to occur. Patients who wear shoes that aren't very supportive, or men who wear very casual or dress-style shoes that have really hard soles, that can cause plantar fasciitis as well. So those are the main risk factors for developing it.
Yeah, I've never had this issue before. It's only been in the last couple of months. And I'm trying to think back. You talked about doing things you wouldn't normally do. I pitched in a softball game, which I do about once every year, and pitched a long time and probably stretched in a way that probably hadn't in a long time. So that could cause it?
That definitely could have been the cause. Anything that's outside of what you normally do, especially in regards of stretching or activity.
Okay. Now the good news is there are ways to treat plantar fasciitis. So let's talk about some of those.
Personally, I like to break down my treatment in tiers depending on how severe your pain is. Usually after I've listened to your problems. I've done an exam. Most patients are looking at me like this lady is in the picture, like what in the world am I supposed to do? Usually if there's no medical conditions that tell us we can't use NSAIDs like Advil or Aleve, we use anti-inflammatories to break that acute inflammatory cycle. I have patients do icing to the heel. No one likes to ice. I don't like to ice. Heating and soaking feels better, but icing tends to work better for plantar fasciitis.
And when you say icing, that could, one, mean dipping your foot in an ice tub. Another friend, a colleague of mine, suggested getting a water bottle, freezing the water bottle, and then rolling your, you go back, I guess, to the wider shot here, rolling your foot over the water bottle like that.
That
yes,
is exactly, that is exactly what I tell patients to do.
Okay.
Putting the entire foot in ice, to me, that's kind of torture. I can't really stand really cold things. So most patients can tolerate a frozen water bottle, and it ices the exact region that we need to take care of. And later on in the presentation, I do have a picture to show you that. I also do steroids for patients. If your pain isn't that severe, if it's just starting and it tends to wax and wane, usually icing, anti-inflammatories will do the job. But if that pain is really severe, if it's like a 5, 6, 7, 8 out of 10, then we look into doing steroids. And with the steroids, we can either do oral steroids or a steroid injection directly into the heel. I have patients do offloading with heel cups, heel pads, different inserts to put into the shoes, and then also physical therapy for that recalcitrant plantar fasciitis that just doesn't want to resolve.
Okay. Now, somebody was telling, in fact, a member of my crew was talking about a boot. You can buy at the drugstore, $15, at least that's what she said, and wear that at night and do the trick.
She's correct. So that boot is called a night splint. Basically, what it does is it will stretch the foot and stretch the fascia while you're asleep at night. By having that fascia continuously stretched while you're asleep, it's going to decrease that post-static dyskinesia, which is the pain you get after periods of rest. So that's what the boot does. It does a constant or continual stretch. For you, that will be very beneficial because most of your pain is in the arch, not on the heel. So that means your pain is from tightness of the fascia. So continuous stretching will help. Also on the image you can see on the left, I have patients do this stretch. This one is going to really stretch the Achilles tendon, which can also play a part in plantar fasciitis. In the center we have the image of the icing with the frozen water bottle.
There we go.
Exactly. That one works wonderfully. And then the last picture just shows a good plantar fascial stretch to stretch that plantar fascial band.
And so I didn't have it. I have it now. You give me ways to get rid of it. Is it going to be gone forever? I mean, the friend of mine who told me about the water bottle was a runner, a serious runner, had to stop for 3 months or so, and right after that, he's never had the issue again that I'm aware of.
I tell patients, whatever you get once, you can always get again. The biggest thing with plantar fasciitis is changing your activity or changing whatever you were doing that caused it. For you, if it was pitching, maybe doing some stretching exercises before pitching. For some women, it's the type of shoes they're wearing, so I'll say, hey, don't wear that shoe anymore. Change up the style of shoe. And usually, most patients get it resolves.
Okay. And I gave up no runs for 4 innings and then 8 runs in the last inning. So my teammates would say, never pitch again. And that would probably be good advice. So good advice on plantar fasciitis. So the next thing we want to talk about is bunions. What are bunions? What causes them? And what are the symptoms of them?
Well, bunions, simply put, for most patients when they present, it's going to be, hey doc, what is this bump growing on the side of my foot? And that's the main thing that most patients notice. As you can see on the picture on the left, there's a large bump right at the great toe joint. That great toe starts to kind of lean over towards the second toe, as you can see a little bit more clearly on the x-ray.
It's a little more pronounced in the x-ray,
but it is.
On the left too.
I tell patients all the time, for me to really tell you how severe it is, I definitely need to get in there and see the x-ray. So with that bunion, it's more than just the bump on the side of the foot. A bunion is a malalignment of that great toe joint and that metatarsal.
It's not extra skin.
It's not extra skin, it's
right.
all bone. Sometimes you can develop a bursal sac in that area, but bunions are all bone, okay? That bunion starts to kind of deviate over to the side, and when that happens, it can give patients some discomfort. Common symptoms patients present with are gonna be pain with narrow shoes, or a lot of men have pain when wearing their dress shoes on Sunday. I have a lot of patients who are plumbers and they do AC work and have pain when they're squatting or stooping, because with bunions, over time you do develop arthritis in that joint. And whenever you're squatting, that joint jams up and can cause an inflammatory response. A lot of women come in and they have the inability to wear really high heel shoes, because once you're in a heel really over 3.5 inches, especially a narrow heel, you jam that great toe joint. So that's going to cause inflammatory problems to set in. Most patients, their main problem is the prominent bump, especially a lot of my younger female patients. They want to know, doc, what is this that's growing on top of my foot? And then another common problem is shoe distortion. Their shoes are becoming stretched out at the side of the bunion, and it's unsightly for some patients.
What causes bunions? Is it normal wear and tear?
Yes and no. So there's a variety of different things that can cause bunions. For some patients, it's wear and tear. You live long enough, things are going to start to move, ligaments are going to give way, things that weren't in one place when you were 30 are going to be in a different place once you're 70 or 80. Genetics plays a big role in bunions as well. A lot of patients, their mom, dad, grandma, great-grandparents had bunions, so I tell them you definitely got it honest. Really narrow or pointy toe shoes can cause bunions to develop, or women that wear really high stilettos, because that puts a lot of pressures on that great toe joint, and that can cause bunions to develop.
All right. Do most people who get bunions develop them on both feet?
Yes and no. Generally, patients will have some symptoms or signs of a bunion on both feet, but there's always going to be one foot that's the worst. So there's going to be one foot that's the prominent foot. That one's going to have the largest bunion, maybe the most pain and inflammation. Then the other foot usually just kind of starts brewing.
All right. How do you measure the severity of a bunion with patients?
Well, if you were to ask my patients how do you measure the severity, they would say the size of the bunion they see clinically. How big is the bunion? And as you can see on this picture, we rate that from mild to severe, going on just the size or deformation at that great toe joint. For me, pain is my motivator. I tell patients, how much pain do you have? You can have a bunion that looks severe, as the picture on the right, but it's pain-free. To me, that's a mild bunion because it's not causing any pain. It's not affecting your activity level. If you can still do all the things that you want to do, your bunion's not severe to me.
But so we're going to talk about treating bunions next. So for someone who's in no pain at all, are you treating it, or are you just saying you need to buy larger shoes?
For me, I'm saying you need to buy larger shoes. If you're not having any pain, if it's not broke, don't fix it. Just leave it alone. If it's a cosmetic purpose, then that's something different. But generally, I tell patients, if it's not causing you a lot of pain, if it's not decreasing your activity, then leave it alone. In regards to trying to treat the bunions, I'm going to break that down into conservative and surgical treatment options. With conservative, it's going to be NSAIDs. That's going to be your Advil and your Aleve, assuming that there's no medical conditions that say you can't take those medications. Main goal with that is to break the inflammatory cycle that starts within the great toe joint. Next is icing. As we previously discussed, no one likes to ice. I like to tell patients to ice because it's effective. Steroids, assuming that you have no medical conditions that say we can't use them. Orthotics, they help a lot. Orthotics, they're not going to make the bunion get better, but they can stall it at the stage it is now. And
unless you've had a bunion, you're wondering, what is an orthotic?
Thank you. An orthotic, that's a very good question, is a custom insert. So if you go to your local drugstore and you buy an insert over the counter, that's just a little insert that you buy. An orthotic is an insert that's custom molded to your foot. You would go to an orthotist, and he would either have you step in a box, or they would take a mold of your foot, and from that mold, they will build an insert that's custom to your foot. And the goal would be to neutralize the forces in that foot.
It almost sounded you described braces for the feet.
You know what? That's a very accurate description. So orthotics do help with some patients, and the biggest thing, properly fitting shoes. You'd be surprised how many people come into my clinic and they don't know their shoe size. And they're wearing shoes that are either too small or too large. For patients who conservative therapy isn't working for them, or they're just interested in doing something more advanced, then we talk about surgery. And there's several different ways to correct a bunion. A lot of it just depends on the severity of the bunion, clinically and radiographically. So as you can see in the picture here, we have a great before and after on this image on the left that shows a very large bump, and then the after picture, it looks nice and straight and smooth. With doing this surgery, we do make a cut in that metatarsal to straighten that bone out. We're going to alleviate that malalignment that's in the great toe joint and cut off that bump on the side. There's several different methods that we use to correct it, and lots of different internal fixation that we use to correct it.
I read somewhere in preparing for the show, there's more than 100 different types of bunion surgery.
Yes, there's a lot of different ways to correct a bunion. It depends on surgeon preference, patient's body habitus, patient's age, and the type of bunion that you have. Most of the time, those bunions are going to require internal fixation, and as you can see on the image to the right, we use screws, we use pins, staples, and everything is meant to stay within the body.
You only have to ask this today because of all the issues at airports with metal. So are those, am I going to get through the metal detector with metal in my foot?
You should be able to get through the metal detector, yes.
Okay.
Yes.
If not, you get doctor's permission, right?
You can get permission or you can get a card, but most airports have the little body scanners now also. So you can definitely say, hey, I want to do the body scan.
Okay.
So that's an option.
Goals for bunion surgery, can you get back to near normal or normal?
You definitely can. So the main goals with bunion surgery is going to be to, again, correct the malalignment of that great toe joint, get that metatarsal back in the proper position. The metatarsal is the long bones in the foot. Of course, remove the painful bump, and restoration or fusion of the joint space. So if you're having a lot of pain with flexion in that joint, we're going to either go in and just clean the joint up, or sometimes we choose to fuse the joint. The goal of fusion is no motion equals no pain. So if we fuse it in a slightly flexed position, you can get back to your normal activities. The only thing patients may have to modify with a fusion is if they're doing yoga or Pilates, because you're really rolling up on the ball of the feet. But outside of that, back to your level of activity.
And let's talk about the recovery process for bunion surgery.
I usually like to overestimate. I tell patients if I tell you it's going to take longer and you heal in a shorter period of time, then I look like a rock star. So generally I tell patients count on a 2-month recovery process, at least 6 to 8 weeks. And that's going to be from surgery to returning to your normal shoes. With post-operative period for bunion surgery, initially you're going to be totally non-weight bearing. So that's going to be offloading, no pressures on that surgical foot. Usually
in a boot, right?
Yes, so it depends on the surgeon preference. Sometimes we'll do a cast or a boot or even a little removable shoe. So you'll be offloading or non-weight bearing for about 2 weeks, and then there's gradual weight bearing into certain types of shoes. We can do walking boots that patients can walk in, or you can rent those little scooters and scoot around. Pain management, definitely with pain medications. And the biggest one is RICE, resting, icing, compression, and elevation. Elevate, elevate, elevate.
And then we've got pictures of the boots and the cast there too, so you can see, again, how you're moving from one phase to the next.
Exactly. So most doctors will go clockwise, starting with the cast to the removable boot to the removable shoe.
All right. Well, we've covered heel problems, we've covered bunions. Now we want to talk about fungus. And first, let's start with foot fungus, sometimes referred to as athlete's foot, right?
Yes. So foot fungus, probably the second most common thing that gets presented in my podiatry clinic every day. There's a fungus among us. Whenever patients say, where did this come from? There's a fungus among us. Fungus is everywhere. So we're going to talk about tinea which is the medical term for athlete's foot, and then we're going to talk about onychomycosis, which is toenail fungus.
Symptoms would be what? Itching, probably a good place to start.
That's going to be a big symptom with tinea but all forms of athlete's foot don't itch. Most of them do. You think about jock itch, that's fungus, you know, in the scalp. So itching, redness, scaling or flaking skin. A lot of times in between the toes, there's a lot of maceration or the skin looks real white as if you've been in a swimming pool all day. That's going to be the main characteristics for patients when they present to the clinic. Also, sometimes there's just excessive dryness or blistering to the feet. There are some forms of athlete's foot that has small blisters that will develop on the foot, and a lot of patients will confuse that with infection.
You said dryness or scaling, but really isn't a lot of this caused by dampness and darkness?
Exactly. Fungus thrives in warm, dark, moist environments. That's why patients develop in warm, dark, moist environments. On the body, you get athlete's foot, jock itch. Ladies get fungus underneath the bust or underneath the arms, dark, warm, and moist.
And you said there's some other causes too that most people don't think about. Barefoot walking?
Yes.
Yeah.
So those fungal spores, they can live off the body. So if you're walking around barefoot, you can definitely pick up a fungus. A large amount of patients get fungus infections from pedicures. Going to pools, going to saunas, those are warm, dark, moist places. Direct contact is another one. So if your partner or if your children have fungus and you use the same shower, you can definitely pick that up. And patients who have excessive sweating to the feet, because their feet are just so moist all the time, it's the perfect breeding ground for fungus.
You know, we're in a day now where you seldom see a shirt that isn't a dry wick, especially polo type shirts and those sorts of things. Have the sock manufacturers kept up with that? And has that been, socks that would keep the moisture away from your feet? And would that be helpful?
They actually have kept up with that. And there are some dry wick or some anti-moisture socks you can purchase. I tell a lot of patients the biggest thing is if your feet are sweating a lot in your shoe, the dry wick socks help to a degree. I tell patients change your socks midday. That's the easiest way to really calm that down and help to stop the breeding of fungus.
All right. So short of preventing it, and you've talked about some of the ways to do that, how is it treated, best treated?
There's a multitude of different options for treatment. Normally, we start with either an over-the-counter or a prescription antifungal cream. That works for most patients that have a fungus, and that cream is applied liberally to the entire foot at least once or twice a day. Extra caution when using public showers. That's going to be very important for kids going to college. A lot of patients pick up a fungus using showers in the gym, saunas, pools, and finding ways to manage the excessive foot sweating.
Okay. You would think chlorine would help with that?
It helps in the pool, but it's around the pool that's the problem.
Gotcha. Okay, so not to be confused with foot fungus is nail fungus, and it seems like we hear more and more about this just
Yes.
watching television.
So nail fungus or onychomycosis, that is very prevalent. A lot of patients present with it, and as you can see on the image, it presents in a multitude of different ways. The mild fungal infections are going to be just slight discoloration to the nail bed. Moderate is when, usually I tell patients more than 25 to 50% of the nail bed is compromised, and then your severe is going to be when the entire nail bed has become thickened and discolored. And for that, I diagnose it either clinically, just looking at the foot, or sometimes we'll take a little biopsy and send it to the microscope to look for fungal spores.
Are the same things that cause foot fungus the same things that cause nail fungus?
Yes, same factors. There's a few extra factors because with nail fungus, it can be using non-sterile nail cutters. So that kind of plays in part with direct contact with foot fungus. If you and your partner share the same nail clipper and they have fungus, you can definitely pick that up. The big pedicures, I have that in capital letters. Very common to pick up a nail fungus from getting pedicures. You don't always know how they sanitize their instruments. If you have tinea pedis or athlete's foot on the skin, it is easy to develop a fungal infection in the toenail and just direct contact with people who have it.
Now, what do you think? Do you think more people actually have it today, or do you think that the companies who have figured out ways to try to treat it, in other words, do we hear more about it, therefore we think more of us have it, or do you think we've always had, that this has always been the issue, but we just never really talked about it?
You know, I really think it's a combination. You know, nowadays in our society, whatever we have that's not right, there's a way to fix it nowadays. Where
Right.
before,
You're right.
you were stuck with it.
Yep.
So now if we're watching TV and we see this, we say, oh, wow, wait, this is something that I have. They say, go see your doctor. So let me go to my doctor and see if I can get this corrected.
Yeah, and even ask your doctor about, right? How many times have we heard that?
I've heard it a lot.
And speaking of it, have you ever said, I'm glad you asked, I'm not going to recommend that?
Very often. Very often.
Okay.
A lot of it is patient selection with a lot of these nail treatments.
Right. Okay, so despite the unsightliness of it, because no one would want to have their toenails look like that, are there some real problems that can develop from nail fungus?
There are some problems. One of the biggest problems that you can develop is ingrown toenails. When you develop a fungal infection in the nail bed, it distorts the nail. It makes it thick, it makes it brittle, or it makes it crumbly. A lot of times you develop a pincer nail where it pinches down on the corners and can ingrow into the skin, or just the thickness of the nail can put a lot of pressure on the nail bed and cause pain. Certain shoes can become painful. For women and men, again, dress shoes, women like to wear heels or anything that bunches the toes up, it can become painful. But the biggest problem I find is the social stigma of having a nail fungus.
Right. And if you ever have to have surgery to remove a nail or something like that, and I know that sometimes can be one of the treatment options, man, getting that shot, that deadening shot in any extremity, whether it's a finger, which I've had, or I'm sure a toe, that's no fun.
It's not the best shot in the world, but it's not the worst either.
Well, let's talk about the treatment options. I mentioned, having to treat sometimes you have to take off the whole nail, right, to get it fully cured.
You know, I actually tell patients I don't recommend removing the toenail. When you remove a toenail for nail fungus, the toenail grows back the exact same way. Nail fungus is extremely difficult to get rid of. And the first thing I like to give my patients is realistic expectations. I let them know straight off the bat, this is very difficult to cure. There's topical antifungals that we could try to use to treat nail fungus. Those topical antifungals are only effective if you have mild to moderate nail fungus.
And where do you put it? Because the fungus is under the nail, right? Are you putting it on top of the nail, or how do you get it underneath the nail?
That's exactly why it's only effective for mild to moderate, because it's all about penetration. So with the topicals, you apply it directly to the nail bed, and then you apply it just underneath the nail. And you do that once a day. If your nail is really thick, that topical will not penetrate through, and therefore it's not effective.
All right. What about the oral ones that we hear more and more about?
So there's only one oral medication that we're really using right now for nail fungus, and that's Lamisil. The oral medication is very effective. It's actually the most effective treatment for nail fungus. However, it's not for everyone. If you have any issues with your liver, hepatitis, cirrhosis, a fatty liver, if you like to drink a lot of alcohol, if you've ever had elevated liver enzymes, you're not a good candidate for this medication. It is a safe medication. A lot of times I tell patients it can affect your liver just as much as Tylenol could, but it's all about patient selection.
Right. And laser therapy or home remedies?
So with the laser nail therapy, the biggest problem with that is insurance considers it cosmetic. So if we're talking one toenail that's affected, most definitely I recommend going in and getting the laser done. With that, it's easy. You just go into the clinic. It takes a couple of minutes to laser that nail to kill the fungus. It may take several sessions. So if you only have one nail that's affected, that's a great choice for you. But if all 10 toenails are fungal, then financially, that just doesn't fit a lot of patients' pockets.
So how does the laser goes through the nail?
It does. The laser goes through the nail to ablate the fungus.
But keeps the nail intact?
It keeps the nail intact. Sometimes the nail can become a little soft after therapy, but that will grow out.
And home remedies, what do some
If
patients tell
to
you? You know what
anyone-
works perfectly?
So everyone has their story on what's going to definitely work to alleviate nail fungus. Vicks Vapor Rub by far is one of the most popular options for that. Tea tree oil has been known to be antifungal. Some patients use vinegar, some patients swear by bleach. So any one of those, I tell patients, hey, it won't hurt to try.
And if it works,
great.
You've saved some money.
Yes.
All right. I want to invite you to call us with your questions about foot problems. Right now, we're visiting with podiatrist Dayna Bolton. Our phone number is 504-866-3200. That's 866-3200. Or you can email us at hhquestions@wlae.com. The last area we want to focus on tonight is something serious. It's the relationship between diabetes and foot problems. So let's talk about that.
So diabetic foot management and really educating patients about diabetes and how it affects the feet is definitely near and dear to me.
It's one of your areas of specialty.
It most definitely is. And it's so prominent nowadays. And the biggest problem is patients aren't properly educated on how it can affect them. So I tell patients the main 3 ways that diabetes affects the feet is it can affect your skin and your nails, it can affect your blood flow, and it can affect your sensation. And those can have very grave consequences for the feet and even your life sometimes.
And what do we see in these 3 images here?
Well, for diabetic, for the skin and nails, patients come in with nails that are just really thick and elongated. A lot of times the nails will look as if they're fungal toenails. They look a little gross, but on the top picture, that's how most diabetic nails look. They get real thick and elongated. They can grow into the skin. The skin gets really dry, cracking and scaling, and that can all be portals of infection. And with diabetes, we want to do whatever we can to reduce your risk of becoming infected.
It almost looks like the paw of an animal there at the top.
You know, it actually does. It does. Sometimes we call those talons when those nails get real thick and start to curve down into the flesh. The next thing that I look at with patients is checking out their vascular disease. The presence of vascular disease for a lot of patients is going to be the leading cause of delayed wound healing or patients that require amputations.
So PVD, vascular disease, who's at risk of developing that?
So the main group of patients that are at risk are going to be our patients who are African American. We're at a high risk for developing vascular disease. Patients who are smokers, patients who suffer from high cholesterol, or patients who have uncontrolled diabetes. And in my practice, I find my vasculopathies, my patients with severe vascular disease, have all 4 of these going on.
Do we know why African Americans are more susceptible?
You know, we don't know why, but African Americans definitely have a higher risk factor for developing this.
Okay. How does a patient or a podiatrist or a primary care physician start to recognize some of these symptoms? What sort of things should we be looking for?
When patients come into my office, they always say, well, doc, you diagnosed me so quickly. And I tell them a lot of what I do is visual. You can just look at the feet and you can see these problems. So when I look at your feet visually, I'm going to say, hey, do you have hair growth? Decreased hair growth is going to be a large indicator on whether or not you have vascular disease, because hair is not vital. And when there's decreased flow, the body just sheds that and gets rid of it. The skin goes through some changes. It becomes thin and atrophic. That can also be a sign of vascular disease for some patients. And the biggest thing I do is just feel the pulse. If I can't feel a pulse, then we know you have some vascular problems that are going on.
I think you've got a side-by-side foot comparison here that we wanted to show people too. There we go.
Yes, so this will be a great image to show you the changes that happen. If you look at the picture on the left, the foot looks a little red, the skin looks thin and shiny. That's those atrophic changes we were talking about. And even you can look at their toenails and see that the toenails are thickened. A lot of times my vascular disease patients, they develop those nail problems as well.
All right. Something you wanted to talk about tonight is neuropathy. What is neuropathy, and how does it impact what we're talking about tonight?
For neuropathy, I like to keep it simple with patients in ways you can understand it. It's going to be a decrease in feeling in the foot. And you want to think of neuropathy as two ways. The main thing that patients notice is numbness, burning, and tingling to the feet. Patients frequently will say, hey doc, I have this problem going on and it's hard for me to describe. Whenever you say it's hard for me to describe, it's neuropathy. If it feels like you're wearing shoes when you're barefoot or your socks are balled up under your toes, that's neuropathy. And that neuropathy is going to increase in severity depending on how controlled or uncontrolled your diabetes is. They're directly correlated. So poorly controlled diabetes, bad neuropathy. And the presence of neuropathy is going to be your number one risk factor for developing ulcerations and amputations. In this picture, it shows the patient's foot stepping down on the knee, on the thumbtacks. And I tell patients that's the second part of neuropathy, where you start to actually lose feeling in the feet. You can be numb, but still have good feeling. Once you've lost the feeling, then you're at a high risk for developing problems. In the next picture, I'll show you what we do in clinic to diagnose decreased sensation or neuropathy is we do a monofilament test. Very simple. I just take a monofilament and I touch the foot in several different places. Just have the patient close their eyes and say yes. With neuropathy, it starts at the tips of the toes and progresses the way forward. So if you can't feel the toes, you can't feel anything else.
All right, last thing we want to talk about is managing risks for some of the things we're talking about tonight and how important that is.
So the biggest way to manage your diabetes is, one, keep your blood sugars under control, and two, establish care with a podiatrist. Some patients will come in and they're going to do routine nail care visits. My routine nail care visits, those are going to be the patients that we consider to be high risk for developing problems. If you're high risk, I don't want you cutting your toenails. I don't want you to put in anything sharp to the feet, basically. Moisturizing the feet daily.
So you give me a pedicure when I'm in there? Or?
If you're high risk, I will cut your toenails and cut your calluses.
Either high risk or high maintenance, right?
And I see both, and I'll take care of it.
All right.
Definitely moisturize the feet, because if the skin becomes dry, it loses its elasticity and it becomes easy to crack and become infected. The biggest no-no for my patients with diabetes, and in my opinion for all of my patients, no barefoot walking. And then also no foot soaks. That's a big thing I definitely want to touch on. Patients don't always realize when you have neuropathy, your internal thermostat is affected as well. So you cannot accurately gauge how hot or cold water is when you're trying to soak. When you test water, what do you use? You use your foot, you use your hand. Those are the two places that are affected by neuropathy initially. So I've had a lot of patients present with second-degree burns from trying to soak their feet and get them clean for me before they come to see me and develop second-degree burns. So definitely no foot soaks.
All right, but swimming's okay, right?
Swimming is okay, unless you have open sores or you have recently healed an ulcer. Swimming is definitely okay. For my patients with neuropathy, I recommend that you wear swim shoes. As you can see in this picture, we have this beautiful lady holding her prosthesis, and that's our number one goal, is preventing limb loss, stopping you from ever needing to get a prosthesis. So keep those blood sugars controlled, keep those nails neatly trimmed, evaluate the skin for calluses and skin tears, and come in to see your podiatrist frequently.
And the ultimate goal, looks like you went crazy here with your pen on the bottom of some toes, or someone else did. Happy feet, right?
Yeah, that's the ultimate goal for everything when patients walk into the clinic. I want you to have happy feet, whether it's a bunion, plantar fasciitis, unsightly toenails, fungus, whatever it is. We just want to definitely be sure that we assess your problems and get you some relief.
All right, we've got a specialist here giving us good answers tonight. We're talking about the feet with podiatrist Dayna Bolton. Our phone number is 504-866-3200. That's 866-3200. And the time to call with your questions is right now. Again, 866-3200. Or you can send us questions by email at hhquestions@wlae.com. I'll lace the shoe back up and we'll be back with your questions in just a moment. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to WLAE and Hello Health. I'm Tom Bagwell. Good to have you with us tonight. We're talking about problems of the feet, foot problems with podiatrist Dayna Bolton. Let's go right to our questions. Lots of people on hold, but still room for you too at 866-3200. Let's go to line one. Barbara calling us from Metairie this evening. Barbara, welcome. You're on Hello Health.
Hello. How you doing?
Well, good evening.
Hi. Good evening.
Yeah, your question. Yeah, go ahead with your question for Dr. Bolton.
Okay, I had a foot problem last week, pain like on the bottom of my foot. It was going on for about 2 weeks, I guess. And I know I have flare-up from the plantar fasciitis, whatever. I can never say that word. And so anyway, I went to the orthopedic doctor at Ochsner. He was a nurse practitioner. Well, anyway, a doctor practitioner. And he took an x-ray, and he said that he said he's never seen calcium deposit. So he even took it to another doctor, the podiatrist, and then they said, well, we can't treat it right now, and we want you to go see a rheumatoid arthritis. So we got home, and we didn't like the way he was said he can't treat the problem right now. So we went to another doctor in Clearview, Brian, I forgot his last name, but anyway, he's a podiatrist, and he took an ultrasound of my foot, the bottom, the heel, and he said it was inflamed. So he gave me some pills to take, naproxen, and some cream because I have a fungus. And then I bought a pair of real good inserts that he has. And it seems to be pretty good, but it hurts. I mean, it still hurts. And so anyway.
Based on what you've heard from Barbara, doctor, what would you recommend?
So with plantar fasciitis, a lot of times you have to get a little bit more aggressive with the treatment if you're having severe pain. So as we discussed, Barbara, initially we like to start off with icing to the foot to help with the inflammation. We do like to do your anti-inflammatories, and I generally would tell patients to take that anti-inflammatory for 7 to 10 days and then reassess. So if you're still having pain after 7 to 10 days, then you're going to want to continue treatment course for an additional 7 days. You know, I don't know your medical history, but you can also consider doing steroids, whether that's a steroid injection to calm down the inflammation or a 6-day course of oral steroids. But if you're having severe pain, your best option at this point will be to see a podiatrist, you can see me, and get an offloading boot just to get the pressures off the foot. It'll be a similar boot to what you saw in the picture for my patients in their post-operative course for bunion surgery. The goal of that is just to rest the heel and get the pain and inflammation to calm down.
Barbara, thank you so much. And there's the picture there of the boot. That would be the one in the upper right-hand corner?
Correct.
Something similar
yes,
looking to that.
exact same boot.
Okay. Thank you so much, Barbara. Let's go to line 2. Helen calling us from Pearl River this evening. Helen, you're on with Dr. Dayna Bolton. Go right ahead.
Hello. Dr. Bolton?
Hi.
I have she's 10 years old now, my granddaughter, and she has a bunion. It's not really large, but her big problem is that she has pain in the Achilles area, and is that referred pain? I don't understand what could be going on there.
So they could just be coincidental, Helen. Patients, is your granddaughter active?
Yeah.
She is. So she's probably developing Achilles tendonitis, which is very similar to plantar fasciitis, and we actually treat them the exact same way. So that's going to be inflammation to the Achilles tendon at the back of the heel. I usually have patients have her try to ice it, take Tylenol, and it's going to be the same stretch for plantar fasciitis, the initial stretch where she stands against the wall, puts the affected foot straight behind her, and stretches or pushes into the wall. That should calm it down. If it doesn't, you can definitely bring her in for an evaluation, because kids that age can also develop fasciitis, which is an inflammation to the heel, and that's just because the growth plates haven't closed yet. So I would try icing, stretching, and a Tylenol or anti-inflammatory, and if no resolution, in about 1 to 2 weeks, bring her in to be evaluated.
Thank you, Helen, for your call tonight. We appreciate it. Lots of calls this evening, 504-866-3200. It may take you a while to get in. Let's go to line 3. John is calling us next from Harahan. John, welcome. You're on Hello Health.
Thank you. Appreciate you taking my call. Actually, I think y'all ran over some part of neuropathy, and I have neuropathy in the left feet right above the toes. Mm-hmm. And I do not have diabetes. And I just want to know what kind of treatment, acupuncture, help it with ice, or what was your suggestion?
Well, John, diabetes is the main cause of neuropathy, but by far it is not the only cause of neuropathy. We're going to want to see, do you have any rheumatological disorders, any inflammatory disorders, alcoholism, depending on your alcohol intake. Another big problem is back issues, spinal issues. And there's a small amount of patients who develop something called idiopathic neuropathy, which means you have it and I don't know why. Over the counter, you can definitely start with a vitamin B complex. That's going to be B6 plus B12. That has been shown to help patients with neuropathy regardless of the cause. There's also alpha lipoic acid that you can purchase. Sometimes it's just abbreviated ALA. That's an easy thing you can start. It's not going to cause any side effects, and vitamin B helps with energy. So you may get resolution of your pain and a little bit of energy as well. If that doesn't work, then I would either see your primary care doctor or you can come see me in the office.
Now, the vitamin B, that's going to be easy for people to find. The second thing you said, a little slower, mm-hmm. and what is there a name that people should look for?
So it's alpha lipoic acid. It's generally going to be abbreviated ALA. I tell patients, just ask your pharmacist. So they'll be able to direct you in the right area. A lot of times they come as a combination pill, but the pharmacist at any pharmacy will be able to direct you to where to go.
Letting them know your neuropathy is your issue.
Yes.
Yeah, okay. Thank you so much, John. Let's go to Chris calling us from Metairie this evening. Chris, you're on with Dr. Dayna Bolton.
Yes, Dr. Bolton. I'm a runner, and I have Achilles tendonitis in one foot. Mm-hmm. I don't know why it's the one foot, but I've been dealing with it. It's been a chronic condition. When I run, I don't feel it, but it's before and after I run, I can feel it. Is there anything I can do for this Achilles tendonitis?
Most definitely, Chris. So most patients will develop an inflammatory issue on one foot. Everyone has a lead foot. That's a foot that's going to get all the pathology. That's a foot that's going to get sprained, tendonitis, fasciitis. That's your lead foot, and the opposite foot just kind of follows through. So definitely, you're a runner, so I'm sure you're stretching before you run, but I would have you add some extra stretches that are specifically for the Achilles tendon. You can look into doing heel lifts. It's a soft heel cushion that'll go into the back of the shoe. That'll elevate the back of the heel, take some tension off of that Achilles tendon, and then definitely anti-inflammatories. Achilles tendonitis tends to be very resilient because your Achilles tendon, it does the biggest job in the foot. It picks it up every time you move. So it can take a while to get the inflammatory process to break. So you're going to be looking at least 2 weeks of an anti-inflammatory, plus stretching, icing, use of a heel lift, and maybe modifying your activity a little bit.
Thanks so much, Chris. We hope that helps. By the way, all our phone lines are jammed this evening, so thank you for all of your wonderful questions, and we've got some emails to get to as well, Doctor. Let's go to line 5. Lisa is calling us, and our top-notch crew tells us she's calling about nail fungus. So, Lisa, welcome. Good to have you with us on the program.
Hello, how you doing? I was calling about foot fungus and the bumps that come around the side of your foot.
Mm-hmm.
Okay, so this is foot, my bad. This is foot fungus, not
right.
Nail fungus, right? Two different things.
Yes, and could you put that picture back up, and I want to know what causes that.
Okay, so Lisa.
This is an extreme case, right? I mean,
no, it doesn't. Foot fungus will not present that way.
Okay, yeah. Okay, there we go. All right.
So a fungus is among us, Miss Lisa.